questions that I wanted to pose to the panel. Because we have such a very interesting, they're all representing a particular part of healthcare, whether it's design, clinical practice, and as Chris had mentioned, he's an actual patient and he's a caregiver. What are some of the considerations that everyone in your field should consider when designing technology for the older adult population? And not any that you've discussed already, but maybe some personal experiences.
Well, I want to reiterate what Michelle said about the time it takes for learning. Remember, I talked about the intersection of the different types of memory, and one of the reasons, so to learn a new piece of technology is going to take more time, and we have to build that into our curriculum. And I know some have individually, but I haven't seen it as the national standard. So when we train an older adult on a piece of technology, we need to do that. And by the way, when I talk to providers have not been trained on how to train older adults to use technology. So we have training opportunities across the board there, not only with the people using this, but the provider team. The provider teams, in some research I did a few years ago, were giving people patient portals, and what they handed them was a piece of paper and instructions on how to sign into the portal. And these older adults then went home and tried to figure out how to sign on to the portal without any training, and the providers didn't have training, so that's really not fair to them either. So I definitely echo what Michelle said about that.
Michelle, can you talk a little bit, I know one of the tweet chat areas was focused on personal decline, especially as they get older, and how that may impact their ability to care for themselves.
Sure. So one of the things that's really important to know is that we're not always trained in geriatrics in specific disease states. We kind of get a general overview, but what are the things that are going to impact someone with a specific disease state, and excuse me, how can technology help them, and what are the things that we need to do? So I can tell you, in my training, I had to go out beyond what was given to me in my schooling to learn about what are the older adult needs. Sorry, excuse me. What are the older adult needs in my specialty, diabetes, and how can I really make an impact? And the training was the biggest one. Not only training of just that individual patient, but everybody who supports that patient. It's really critical to making sure that everybody who's on the team is a player. So if the daughter's going to take that patient out for lunch every Sunday afternoon out of the assisted living facility, she needs to know how to manage that technology. If grandson's going to come visit, he needs to know how he might need to be able to be a player in that technology, especially if he's going to take that individual outside of the facility.
So Chris, I wanted to ask you a question. You had talked about your role not as a patient, but also as a caregiver. Can you kind of elaborate a little bit more on how important it is for family involvement, not just with training, but being part of the treatment plan? Can you give us a little bit insight into that?
It's difficult for me at times because my wife is she's a grown-ass woman. She can take care of herself, but also it's diabetes and it's something that I take very seriously. So if her Dexcom, if her continuous glucose monitor is buzzing in the middle of the night, if it's a low alert, I'll go up and get juice for her. If it's a high alert, I might wait a few minutes and then I'll nudge her at some point in the middle of the night and say, hey, you should probably check that and maybe take some insulin. So I have to manage the fine balance between being a full-on caregiver where some parents of newly diagnosed children, they're going to be all in, they're checking their kids' blood glucose in the middle of the night. I'm not doing that for my wife. That's just not going to happen. So I have to be able to trust that she's going to be able to take care of herself, but also that's my wife, and I want to do everything I can to support her and take care of her diabetes for her, but I can't do that. So it's a really tough balance of letting her be, but also showing that I care and helping out wherever possible. And that's one of those things they don't necessarily tell you at diagnosis. Obviously, they don't tell you you're going to marry somebody with diabetes, but whenever you're caring for somebody with diabetes, trying to empower them, enable them to take care of themselves, trust that they're able to do that whenever they're of the right age and mind to do so, is a big challenge, and it's something that I struggle with all the time because I like fixing problems, and diabetes is a pretty big problem, and it's like I said, these are our lives, and I try to do everything that I can while also enabling her to maintain her own singularity and being able to take care of herself too. I've kind of danced around not really answering your question because it is a really difficult thing for me to kind of rationalize at times.
No, and I think it really does. Go ahead, Michelle.
Well, just to interject a little bit, one of the things that we see in teenagers who have parents who are kind of helping out with chronic disease management is that parent has to let go at some point and let that person emerge as an adult. And we're seeing kind of the opposite, where in older adulthood, we're needing to bring back in support when somebody was completely independent on their own before. And so there's a tricky balance of where do I intervene, where do I not? You know, I need to make sure to intervene if there's a safety issue like a hypoglycemia episode in place, but it's really a tricky balance in how can we support older adults who are declining in making sure that their values are still respected, and then identifying where technology might help with some of that independence too.
And some of the fun of that is that, you know, I'm looking forward to getting old with diabetes, with my wife who has diabetes. So I can, you know, put in my infusion set for my insulin pump myself. I can put in my continuous glucose monitor myself. But I haven't really had training on how to do that for somebody else. And I understand my tolerance for pain and for awkwardness and the right angles for things like that. But I'm going to have to, at some point, maybe have to figure out how to do that for her. Or she's going to have to learn how to do that for me. As you know, as Perry was talking about, our eyes are not going to be as reliable, our fingers are not going to be as reliable, our sense of touch, that sensation. Like right now, my insulin pump is vibrating because I took a bolus 2 hours ago. This thing is reminding me that I need to, check my blood sugar. But I can feel that right now. Mm-hmm. How am I going to be able to feel that? Am I going to be able to feel that in 30 years, in 40 years? Am I going to be able to hear or feel my CGM whenever it's alerting me in the middle of the night? Is my wife going to be able to identify those alerts? And these are problems that I'm not sure if there really are good answers to. I think that as technology improves, maybe we can put a more high power motor in this thing. So it's like there's like an older mode. You hit that button, and then it's going to cause a little seismic shift in the house. As technology improves, there are ways to you connect your CGM to the cloud, and you can have some big alert system throughout like a high tech house. So lights start flashing whenever there's something that needs to be treated. So there may be means to address that kind of stuff, but there are much bigger concerns that I hopefully have to look forward to as I age with diabetes and as this technology ages and hopefully improves with me.
Well, and that you bring up an interesting point about feeling it and your insulin pump. And as older adults, there's a lot of cognitive decline, as Perry talked about. But what if an older adult feels that vibration but doesn't know what that vibration is for? So that's something definitely we need to consider as well when working with this population. So as an emergency department nurse, I have an affinity for the older adult population. I absolutely love them, and I think we can learn a lot from them. And it always broke my heart because it's a rarity you ever see a pediatric patient alone, right? They always have their parents, they always have a guardian, but it's very common for an older adult to come into the emergency department absolutely alone, without any information, no one to provide us a health history. And it's gotten better, but it definitely is an area of healthcare that we need to become better and become equal partners, and not just the patients, but also their families. So we talked a little bit about, Michelle, you talked about some of the training issues. And it's very apparent that this is a huge piece. What kind of advice can you give providers who may be interested or who are thinking about incorporating technology? What kind of considerations should they include in terms of providing time for training and what that may look like, and how can they prepare for it?
Well, in my space, I'm in diabetes, and I think that diabetes educators are underutilized, and I think that educators are perfectly trained to train others, and so I think we need to identify who the resources are. I also think that we need to be doing a better training in the schooling system, so as we're producing new physicians and nurses and other clinicians, we need to make sure that they understand what technology is. As we see a higher boom of adults with technology for diabetes, like insulin pumps and continuous glucose monitors. As they age, they still want to keep those devices. And right now what happens, if you go into a hospital system with an insulin pump, you're told to take it off. And I don't think that that's necessarily always the right decision. Patients who have insulin pumps know how to manage their disease state. Of course, there's other considerations, like if someone needs an antibiotic, they've got an infection, insulin demand's going to change. But I think if we talk to patients, and we've trained nurses and physicians and other staff in the hospital system, how can we use this technology while someone's still in the hospital system for the better, using temp basal settings, using different types of bolusings. I think that we could definitely improve the care related to technology in older adults.
Okay. So Perry, we were talking, I briefly mentioned iPad technology, and you and I worked on that project, and we discussed a little bit about the patient portal. Can you tell us a little bit more on how the iPad and that can help with older adults?
Well, one of the neat things, if you haven't seen it, it'll be coming to a hospital near you, which is this patient engagement technology. Sometimes it's on an iPad, sometimes it's on a television screen. Whatever it is, it's coming in and it's feeding patient information, it's feeding education, but it's also providing a portal that then it's an opportunity for us to train people at that time how to use their portal, the importance of the portal, how they can reconcile their medication list in that portal, how they can check some of their own personal information in the portal to make sure that it's correct, and how they can use it at home. So that's an opportunity where you have a captive audience, not only to have the patient, but their caregiver or family member say, look, here's what the portal is like. When you get home, you're going to see something very similar to this, so it'll help with that transition of care. And the other thing that I like about this iPad technology is that patients frequently say, I want to talk to the pharmacist. I don't just want to talk to my physician. I want to ask the physical therapist a question or the nutritionist. These portals are offering an opportunity for you to speak with, at least in the hospital, everyone on your care team. And so that gives the patient some empowerment. They feel like they can go ahead and that they don't remember what the nutritionist said the day before. They were in too much pain. But now they're thinking back, before they go home, I really want to check with that person. And there is a way they can communicate.
Thank you. So I want to give us some time for questions from the audience and to answer any questions that have been tweeted. Are there any closing remarks that you guys want to say to the audience?
Somebody liked my granny mode comment. The fact that we need an older person mode for diabetes technology, which is, I mean, you brought a prop. I'm not sure if it's going to play for the camera, but it's something to consider that that these devices, like right now, they're targeted for a certain generation of people that are, not necessarily just tech savvy, but also all of their fingers work as intended, and they can hit the buttons, they can feel all the different vibrations and things like that, and the design of some of these things, whenever they are trying to cater to a different audience, is severely lacking. I mean, I'm just throwing it right to you for the meter.
So a few weeks ago, I was following, if you get a chance, Google Dr. Larry Chu's health hack that he did last year. And it kind of inspired me. I wasn't feeling very good, so I thought, I'll look at his health hack. And one of the things he did was he bought his own technology. He bought his own blood glucose monitor, and he went and got his own lab work. So I went and got my own lab work, interpreted my lab work. I haven't talked to my provider yet. I don't know what he's going to say. And
is he watching?
Gosh, I hope not. And my
everyone is included, though. He's the one.
Everyone's included.
It's okay.
My A1C is getting pre-diabetes, and my finger stick blood, or my fasting blood glucose was pre-diabetes. So I thought, I better go check this out. So I went. The first thing I did was I did not. By the way, I'm the technology chair for the American Association of Diabetes Educators. I did not check with any diabetes educator or my friend Michelle here, but I did contact the doc and my friends at the doc, and I said, what kind of blood glucose monitor should I use for home? And I won't say the brand, but several of them sent me this brand. They suggested this one. So I asked them. Brandon Arbiter, do you guys know Brandon? He was the last person, and I used his suggestion. So I went to the grocery store. I bought this glucose monitor. I brought it home. I've done this thousands of times in my career to other people, not to myself very often. And so I opened the jar, and I thought, okay, I'm just going to test my blood. Well, I had trouble getting it out of the jar, and I'm not shaking yet. But my fingers are pretty sore. I was raised on a farm. I did a lot of work with my hands growing up, and I have a little bit of arthritis, I think, starting in my hands. Plus, I type all day, every day. I had a hard time picking this thing up, okay? And then I had a hard time putting it in the slot. And I'm kind of this healthcare IT expert, I think. And I thought, this is going to be a slam dunk. Well, it was kind of hard. And then lining things up. And I'm thinking, I'm trying to fast forward to myself at age 75 now. What's that going to be like? And I remember watching my father, who had type 2 diabetes when he was 75 years old, and he was shaking at the same time, and no wonder he couldn't manage himself. And so I know there's designers in this audience probably, certainly, or I know there's a designer backstage right now who could design a better system for an older adult who's going to have shaky hands and things like that. I know, and then when I pulled this out, these two immediately said, well, this one's not small, this is a big one.
That is a monster in his hand.
So
I can confirm.
And to add to that, I think that the casing is important too. So when glucose test strips are exposed to light, they're not as effective. But some older adults who have arthritis really struggle with opening up just the canister. And they leave it out on the table like this so that they don't have to open it anymore. Same with medication, just the prescription pills. And so I think that we need a better design for people who are older, who have arthritic hands that can't really use their strips the right way because they're exposing them to light.
I mean, maybe if I had planned this out better, we could have played a video of me doing an infusion set change, or changing some of my Dexcom stuff so that you can see all the precision that is required. I mean, the process is pretty efficient, but there are some really tiny needles that are involved in getting the insulin from the vial into my insulin pump, and then I've got to manage the tubing and hold it up for a while there's a whole process to it that I think is taxing, and I'm a pretty healthy, moderately patient person. So anybody that is beyond that it's just, these are more design considerations to take into effect when it comes to considering the fact that as this technology improves, young people with diabetes are going to become older people with diabetes, and we need to account for that, and not just in that initial diagnosis phase or in that younger, more mobile phase. We need to be aware of the fact that this is going to be a concern for a really long time, unless somebody wants to share that cure anytime soon. I don't know what else we can really think about.
Do we have any questions from the audience?
Is there a
Oh,
microphone?
perfect.
We do.
There's a mic.
We're going to have a microphone come over, I think.
Thank you.
Number 1.
Thanks. Good morning. I just wanted to thank you all for doing this. This is a really good topic and important. I just wanted to ask about HIPAA compliance with texting. Can you address that issue, whether texting and which text messaging service you would suggest using for HIPAA compliance?
And I've worked with a lot of providers who, this comes up a lot, but most of them give their patients, a lot of the primary care, will give their patients their phone number and say, here, if you have any questions. But at this point, they've established the relationship with them. I do know that there are a lot of these new type of services, or concierge medicine, where it is that very similar type of approach. So I can't specifically answer your question about HIPAA. I think it's specific to the service, but I think it's almost, social media is just as important as having that phone call over the phone, and sometimes you reach more people via social media than you do with the simple phone call. But that's a great question.
I can make a...
We have a question back there, number 2.
Well, my name's Joy Pritz, and I'm speaking later today, and I can actually answer this question.
Thank you. Perfect.
So texting is a very interesting and kind of complicated issue, but to boil it down, the reason it's complicated is a lot of text service providers, actually there's an aggregator in the middle between when the message is sent and when it's received, and they tend to keep their data. They don't just pass it on, they keep it from up to 2 years, and that's where the issue is, because they're actually storing the data. But it turns out that if a provider actually talks to a patient and says, I can send you text messages, but they're not going to be secure, and the patient really wants that, you document that, you can send them a text message.
Perfect. Thank you.
One comment I'd like to make is I've actually worked with an EMR that actually had a texting component to it, but it was one way. So I could send the patient a text, but there was no way to receive, which isn't fair to the patient. And so we need a better design of our electronic health records so that we can actually have that two-way function. And while I'm talking about design, I'm just going to plug that we need to be able to have patients be able to send us attachments too. And I know that there's concerns with viruses, but really if you think about someone who has a wound, if they could take a picture of that wound every single day and show you progress, or if someone wanted to send an attachment of their pump download or something and send it in the electronic health record, we need a better design for patients to be able to give us information.
Well, I think that concludes our time. We want to say thank you to Perry Gee, Michelle Litchman, and of course Christopher Snider for joining us today, and for you all for joining us and talking about this very important topic. Thank you for this opportunity.
Thank you.